We're going to talk about the neurological exam in the emergency department or urgent care, and understand this, it's the most common exam you do. Why? Because of the 25 most common chief complaints in the emergency department, 10 of the first 25 are neurologic. When you think about it, back pain, it's a neurologic exam. Headache, it's a neurologic exam. I'm dizzy, I'm weak, I can't see, I can't do this, I can't do this, and the worst all is grandma's not right. Oh, shit! You know, there's 5 minutes left in your shift, and the nurse says, "Would you see one more patient?" And it says, "Grandma's not right. Just shoot me, okay? Just shoot me." So, if this is Grandma, hi, Grandma. Understand that the neurologic examination should be done just about the same way every time. And what happens is, whenever it's a yes or no question, does the right eye go in or out? You're pretty good at that. What you suck at are those things that are much more subjective and have to do with the cerebral parts of the head. And more you are getting people who bring in Grandma, right? Now, they say she just got worse today. Is that true? No, families lie. More than that, they've all come from 500 miles away to celebrate Thanksgiving, and Grandma's not right. Well, Grandma hasn't been right for the last 6 months, but they haven't bothered to see her or call. So now you got to work through their guilt, all right, as well as everything else. But, doctor, what's the problem? I said, she's got you as children. That's the problem. Holy Jesus. All right. I'm going to give you some things to start out with. First of all, stand up for me again. Walk over this way. And she's coming into the room. Now, come in. Have a seat. Thank you very much. You notice she followed direction. She moves both sides of her body normally. She's not doing this sort of thing. All right? I do that sort of thing. She's not doing that sort of thing. She's paying attention. All these kinds of things. One of the things you should be noting in the neurological exam is, we're going to give you a couple things, because when they say that she's not right, what do you mean, not right? If you want to know if somebody, let's say she's 75 or 80, is not right, you talk to them. Now, I know how frightening that is, but you sit for just a second, and I'm going to show you what to do mental status-wise on most patients. I'm going to give her 3-object retention. Grandma, as we sit here, I'm going to ask you to remember 3 things, okay? A banana, a monkey, and a piece of paper. What were they?
A banana, a monkey, and a piece of paper.
Now, that's very good. You notice she has 3-object retention over 15 seconds. That's a good thing. Anybody who doesn't have 3-object retention over 15 seconds is questionable, and if they don't have it, now I'm going to come back to her in a minute, if she can't remember 2 of the 3, is she safe to go home? I'm going to raise a different issue here. It's not just the examination, but a question falls on you is, how is it safe to work up the patient? When a family brings somebody in, one of the most important things you can do is determine what the home situation is. Are we going to find her at the bottom of the stairs in the morning? Can she take care of herself? Will she turn on the stove and burn the place down, all of these sorts of things. So if you've got to put something down on the paper, and most neurologists would agree with this, 3-object retention over a short period of time is extremely useful. That's reproducible. It's something we can talk about. What were those 3 objects?
Banana, a monkey, and a piece of paper.
That's pretty good. She's got 3 objects over about 2 minutes. And so we know that that's all right. Here's the next. I'm going to give you a trick right now which will diagnose more people having intellectual problems than any other. It's called follow 3 directions. As we sit here and talk, I'm going to ask you to do 3 things, okay? I want you, when I say go, to take your right thumb. Show me your right thumb. She has right-left orientation. I'm going to ask you to touch your left ear. Then I'm going to ask you to close your eyes. In fact, the first thing we'll do is close our eyes so that we don't have any other things that give you clues. Take your right thumb, touch your left ear, and stick out your tongue. Are we ready? Mm-hmm. Go. 3 objects. Now, what did we just learn? She can maintain right-left orientation. She can do it without visual clues, and she can do them in order. I'm going to give you a little advice. If you've got a patient who the family says is confused and cannot do cross the midline 3 objects, you've got somebody who's a danger to themselves or others. And as soon as you see that, this is an objective way of putting down what the family is complaining of, which is she's not right. She can't do this. She can't do that. No neurologist and nobody admitting the patient wants to hear that stuff. They want to know, is she a danger? What can they do? What can't they do? All right, next thing we do is we do her cranial nerves. Now, you all write down cranial nerves 2 through 12 intact. You never check all that. First of all, did you hear her speak to me? You did. I mean, she did speak to me, and it sounded normal. It didn't sound like this. So the chances she got something wrong with her 12th cranial nerve are very small. I want you to look right at me. Turn this way a little bit. Very good. Which finger moves, right or left?
Both.
Yeah, now?
Both.
The chances that she's got a visual field defect are very small. Now, if we had a problem, we'd have to go through and isolate those things. She doesn't have it at this moment in time. Watch my hand. Don't move your head. Now, if one of her complaints was she couldn't walk, or the family's complaint, is she somebody who's having some sort of problem with balance? She has smooth pursuit, both eyes, side to side, up and down. If we want to go through the hints exam, if their chief complaint is vertigo, is dizzy, and we're going to do a hints exam, this is the beginning of doing that hints exam. Now we have a few other things we need to do, including alternate cover, looking at the skew deviation, these sorts of things. But if somebody can maintain their vision, and they have smooth pursuit across the middle in all directions, the chance that they've got an internal lesion, something central causing this, are extremely small. It's virtually 100% reproducible if you get good with this. Very useful. Now, smile. You notice she moves all 3 divisions of her face. Stick out your tongue. You're done. And what you're going to say, well, you didn't check. And by the way, I never put down 2 through 12. I put down what I actually do. Am I actually going to do her 10th and 11th nerve if she's swallowing and she's otherwise okay? No, and I'm not going to lie about it. Do I really need to do a gag and all these sorts of things? No. You've got an adequate view now of her cranial nerves. Next, as you're looking right at me, okay, we're doing well. She doesn't look away. I want you to close your eyes. I want you to point the door where you came into this room. Thank you. She's still got a map, a neuro map in her mind, how she entered the room, what she did. If you take lots of grandmas, people from the nursing homes, that sort of thing, sit them down and ask them that question, they cannot do it. It's not part of the deal. Now, when you're doing her motor examination, there are things which are more important than others. I promise you this. I want you to stand up for me. Okay? Feet together, arms at your side, close your eyes. Romberg's normal. Now, I want you to watch a test which is, again, virtually 100%. When they say she's weak on one side, can't do this, can't do that, I'm going to ask you to, when I say go, stick your hands out in front of you and keep them up. Ready? Go. Close your eyes. Now we've taken away visual input. You notice that she keeps them exactly the same height. There is no movement. There are only 4, you can put it down now. There are only 4 possible responses. The first one is hers, which is normal. What does it mean? She's constantly monitoring where her limbs are in space. She doesn't need visual input. When I ask her to put her hands out, if you'd seen this, family said, well, she hasn't been right. I think this side of her body doesn't work right. If you watch this, close the eyes and you see this. That's or better way would be like this. That's pronator drift. That means she is not sensing both sides of the body the same, and she's not making adjustments for where she is in space. Number 2 would be this. Grandma, stick your hands out. Close your eyes. You notice they stay there. You can put it down. This is the one that no house officer can ever do because they get mad at the patient. Grandma, stick your hands out. Close your eyes. Grandma, stick your hands out. Close your eyes. What's that? Without visual input, they cannot maintain a part of the motor examination. Whenever you see that, that's frontal lobe disease till proven otherwise. They are not monitoring what's going on with their body. And when you see that, these are also people who are not keeping other things at the top of their brain, like the fact that they've got a cigarette burning in the next room. They've got a pot going on the stove. When you see this, they cannot maintain a motor activity. And that's a serious problem. And you need to understand that. Now, there are bizarre variations of this. There's this one. In parietal lobe lesions, you sometimes can't remember where things are. And so you'll ask them to go like this, and again, they'll get a searching or a movement in one arm because they're not monitoring in their parietal lobe where the other extremity is. If you see that, it's unusual, but we know where the lesion is. Sometimes the very short examination, rest of it, you can tell what's going to be on the CT scan before you shoot it. Whenever you see that, one arm searching, that's the non-dominant parietal lobe. Again, 4 findings. Maintain it. That's good. All right. Then there's impersistence, motor impersistence. Close their eyes and it's down. Then there's pronator drift. They will not keep it and it drifts down. Often seen with people who have had strokes, minor strokes where they can have the initial activity, and then you have the motor impersistence where they, or the parietal lobe lesion where they can't keep things going. Let's do a couple of other things while we've got her up that's useful. When you have somebody stand like she is, and now close your eyes, you notice that she's not putting a foot out. Whenever you see someone, when you say close your eyes, if they have to put a foot out to stabilize themselves, that means their central balance system is missing input. They're not getting what they need. There's information coming up, but it's not enough for her to overcome gravity, and she has to do something to stabilize the body. Whenever you see that, what you know is centrally, where they are controlling their balance, they need help. These are the people they put all those handrails up for in nursing homes. Because going down the hallway, they got to grab something. And oftentimes, they're not getting enough input from the rest of the body. You realize you're getting 4 sets of inputs all the time. If you have mild peripheral neuropathy and you don't know exactly where your foot is, what you do is put the foot out to the side. And you want something else to stabilize yourself, and so you reach for the handrail. Watching them come in, watching them move down the hallway, you can pick out the disease entity almost every time, but you have to look for it. Now, the last few things we'll do have to do with the specific complaints. I'm not going to go through her hearing, all that sort of stuff. But understand in her motor activity, reflex functioning is still important. Have a seat. So when I do her reflexes, I'm going to check them on both sides of the body, top to bottom, right and left. Hands are in her lap like that. I don't have my reflex hammer, but I promise you, I can get her to move without any trouble at all, because she's perfectly fine. And she will do the activities. When you see reflexes that are asymmetric, top to bottom, side to side, that sort of thing, then you've got to find the lesion. Most people will have the same reflexes, arms, knees, and, by the way, jaw. Relax your jaw. I can go like this with her, and I can get a jaw jerk. Jaw jerk, arms, knees ought to be about the same. When you have that difference between the two sides, those are the people who are going to have the other motor problems. When you get them walking, when you get them turning, when you get them moving, because they're actually sending out different level of signal to the two sides of the body. The complete neuro exam, and I've done a fair amount of that right now, It is not hard, but it should be done the same way every time, and you need to put it down in a way that other healthcare professionals, if I put down retention of one object in 2 minutes, there's no neurologist who doesn't know what that means. And it kicks off a whole series of investigations that need to take place. You know, so this rapid neurological examination in the department, and I've got a much bigger discussion of this in my book on neurologic emergencies. So full disclosure here, I am the author of a book in which all of these things are discussed. But remember, neurologic examination is the beginning of all this activity. It is the most common area of complaint that comes to emergency departments. About 10 of the first 25 chief complaints at all departments are neurologic, and certainly 2 of the 5 most frequent, back pain and headache, are almost purely neurologic in their serious effects. You need to be an expert at performing the examination.